Thank you all for coming. I appreciate it. For those of you that haven't seen me before, I'm Katie Braddock. I'm one of the owners of Plum Creek Veterinary Services in Castle Rock. And we're going to continue talking about various types of cancer in dogs and cats today. So first we're going to talk about the definition of a companion animal. The ASPCA definition is a domesticated or domestic bred animal whose physical, emotional, behavioral, and social needs can be readily met as companions in the home or in close daily relationships with humans. And as you can see kind of here, that doesn't just include dogs and cats, but also horses, rabbits, ferrets, guinea pigs, birds, small mammals, small reptiles, fish, and even some of the larger domestic bred farm animals can be considered companion animals too. All right, so we're gonna kind of continue with our theme like we did last time. I picked basically 3 different types of cancers in dogs and 3 different types of cancers in cats. So in dogs today, we're going to talk about mast cell tumors, anal sac adenocarcinoma, and mammary gland tumors. So the first ones are mast cell tumors. Mast cells are normal parts of our immune system found in the blood and can also be found in various locations in the skin. Their primary goal is to defend against parasites. A mast cell tumor, as you can see over here, is an aberrant or abnormal growth of the mast cells forming a cancerous mass. It typically presents as something like this, usually a round, well-circumscribed, red raised mass on the skin. However, mast cell tumors have been kind of called the great pretenders and can really show up as pretty much anything. So diagnosis of mast cell tumors is generally done by a fine needle aspirate, or basically taking a small needle and taking a small sample of the cells in the mass. When you squirt this out onto a microscope slide and stain it, you see the mast cells. And these guys right here are the mast cells. They're kind of this purpley thing, and all these little purple dots are granules. Those granules release histamine, so it can potentially cause kind of an allergic-like systemic reaction. It can cause hives, facial swelling, things like that if they degranulate. Normally, that doesn't happen, but it certainly can. If there can also be disseminated mast cell disease in some of the different organs in the body, and diagnosis of that may include ultrasound or aspirate or biopsy samples of the affected organs. Treatment of mast cell tumors, especially if they're in the skin or underneath the skin, is surgical excision with pretty wide margins. We actually try to get about 3-centimeter margins all the way around the mass. So you may have a very small mass at a very large surgical site, but that's going to be your best chance at a cure. After that, we submit that to the pathologist, allow them to fix it in formalin and then slice it and take a look at it. That allows grading of the tumor. Grading cannot actually be done by needle aspirate alone. It does have to be off of a true biopsy. And there are, in one of the particular grading systems for mast cell disease that I typically use, there's grade 1, grade 2, low and high, and then grade 3. Basically, they worsen as you go up in the grades. Grading provides the prognostic information as well as what else staging-wise or treatment may be necessary. And staging is a little bit different from grading. Staging actually involves looking at the whole body itself, such as thoracic x-rays or x-rays of the chest, abdominal ultrasound, and aspiration of regional lymph nodes, which are the lymph nodes that are associated with wherever the mass is on the body. For higher grade tumors, even if they have been surgically removed, chemotherapy can be indicated, and there's a few different drugs that can be used for this. There can be multi-drug chemotherapy protocols that would be similar to chemo for lymphoma. There are also some newer drugs that actually target a particular mutation that can be present in some of these mast cell tumors, and that would be Palladia and Kineret. Another thing that can be used is radiation therapy, especially if the tumor was not completely excised, because some of them can have more kind of tentacles that actually spread out that you can't really see when you're surgically removing them. For some of the lower grade tumors, it's possible that surgical excision may be all you need, and at that point you would just monitor for any regrowth at that site or other masses coming up. I always advise my clients that have an animal that's had a mast cell tumor, that if any mass comes up on that dog's body, it needs to be aspirated right away, regardless of what it looks like, where it is, or how it behaves. For palliative care, prednisone, which is a steroid, can be used to help shrink the tumor and provide comfort for a period of time. The other thing I'll commonly use with them are antihistamines. Typically I use Benadryl. Famotidine is also a histamine blocker for the GI tract because there are histamine receptors in the GI tract. And I use those just for comfort more than anything. You can see dogs with GI signs because there are histamine, and if you've got a mast cell tumor releasing histamine, it can irritate the GI tract. For prognosis, as we said before, the higher the grade, the worse the prognosis. Grade 1 tumors can often be cured with surgery and then careful monitoring of the body after that. Grade 2 tumors vary a little bit, and unfortunately most of the mast cell tumors that we see are classified as grade 2s. They low versus high, obviously higher grade is worse prognosis. We also use something called the mitotic index, which is something that the pathologist looks at in the cells. Basically it tells how many cells out of a high power field under the microscope are dividing or actively growing. So mitotic index of less than 5 comes with a median survival time of 70 months versus over 5 is 5 months. So it makes a pretty big difference. Grade 3 tumors are very aggressive, and almost always by the time you find them and aspirate them, remove them, have already spread. So they carry the worst prognosis. Anybody have questions on mast cell tumors?
What kind of dogs do those usually?
Can affect any of them.
Any of them?
Yep. I would say probably boxers tend to be pretty predisposed to them, but oftentimes boxers tend to have lower grade disease. But it's a pretty well-known thing in the boxer breed.
Do you see it in a lot of cases?
Pardon?
Do you see it commonly?
Yes, very commonly. Mm-hmm.
I was just thinking about age range. Is there any type of age?
You know, it's commonly older dogs, but I have seen it in dogs that are very young. So that's, I think, how they get their name, the Great Pretender. They can act like anything. They can affect anyone or anything. So. All right, we're going to move on to anal sac adenocarcinomas in dogs. Anal sacs are scent glands that sit at about 4 and 8 o'clock inside the anus. People are probably familiar with these because a lot of dogs have to have them expressed. They are supposed to express on their own when the dog defecates, but that doesn't happen a lot of the time, so we actually manually express them. Tumors of the anal sacs can develop at any age, but this is definitely an older dog disease. And unfortunately, because it's not an area that people routinely monitor, and they don't really show any clinical signs until the tumor is really large and can start to affect defecation. There's a lot of times spread to the sublumbar lymph nodes, which are actually within the abdomen right under the spine. And when those enlarge, they actually press on the colon and can cause some difficulty defecating. The other thing that is pretty well known, there's a paraneoplastic or kind of secondary to the cancer syndrome that causes high calcium levels in the blood, which can cause an increase in urination and drinking, as well as inappetence and lethargy. It's not a very nice syndrome. It also actually happens with lymphoma too. I'd say lymphoma and anal sac adenocarcinomas are probably the two most likely cancers to cause high calcium in the blood. So diagnosis, usually you find these just doing a digital rectal exam, which can be part of your kind of normal physical exam on a dog. And when you go to palpate the anal glands, you feel a mass instead of a normal anal gland. These are, unfortunately, most of the time malignant if you find a mass in the anal sac. You can aspirate them. It's a very vascular area and tends to cause a lot of bleeding when you do so. And most of the time, like I said, they're malignant. So they need to come out regardless of how big or how advanced they are. Baseline blood work, which would just be like a metabolic panel looking at chemistries, looking at red blood cells, white blood cells, platelets, also often shows hypercalcemia malignancy. X-rays of the abdomen can also show enlargement of the sublumbar lymph nodes, which can press on the colon and cause difficulty defecating. Treatment of these masses is surgical removal of the anal sac. It is typically only on one side, but in the rare case that both sides can be affected. Then we submit it again for histopathology to confirm the diagnosis. Radiation therapy can be used to treat anything that's left at the site because it's not really an ideal site to be removing cancerous masses. There's not a lot of extra tissue to be able to get good margins or anything like that. So radiation therapy can be used. Not a great place for radiation therapy, can cause quite a few side effects. Chemotherapy also can be used. We usually use carboplatin, which, just kind of as a side note, is the same chemotherapy that we use for osteosarcoma. So a lot of these drugs have multiple uses. The other thing we can use is the tyrosine kinase inhibitors, such as Palladia, that we talked about with mast cell tumors. Palliative therapy for anal sac adenocarcinoma, NSAIDs are non-steroidal anti-inflammatory drugs. Piroxicam tends to be the top thing to use. It can have some pretty severe GI side effects, so you have to make sure that they can tolerate it. So meloxicam can also be used. Secondarily, they tend to tolerate a little bit better. So prognosis, this unfortunately is not a great cancer to have. Dogs with enlarged sublumbar lymph nodes have a shorter median survival time. They're 422, but even dogs that don't have enlarged sublumbar lymph nodes are only 529. So not a huge difference there, but dogs that are hypercalcemic definitely have a shorter survival time. So, and that can become a pretty bad situation that needs IV fluids and other medications to bring the calcium levels down, because it can actually start to affect the heart. Anybody have questions on anal sac adenocarcinoma?
Does anything cause that? Or in particular, or does it just
Nope,
show up?
it just shows up. There's nothing, unfortunately, I don't think there's anything supporting that, like dogs that have to have their anal glands expressed are more prone or less prone or anything like that.
And you just really you won't really see any symptoms except for maybe they're having
Trouble defecating. If you lift up and look at their anal sac area, as it gets bigger, you can start to see a bulge where the anal sacs would be, but usually by that time it's pretty large because a lot of the growth is internal.
So even with removal, it's like a year to a year and a half, basically?
Yeah.
So if you were to not remove it and just treat it, what kind of prognosis would you have? Because it's such a invasive.
I would say they don't necessarily die from the disease at that point, but really from the side effects, because as it gets larger, they're eventually going to get to a point where they can't defecate, and at that point, euthanasia would be warranted. So, anybody else? All right, the last one we're going to talk about are mammary gland tumors in dogs. This one pretty obviously presents as a mass in the mammary chain. In dogs as opposed to cats, because I think we talked about this last time in cats, only about 50% of mammary tumors are malignant, as opposed to cats, it's more like 90%. Risk factors, being female, although males can get them too, but definitely more represented by the females. And again, same with the kitties, spay later in life poses a higher risk. Early spay dramatically decreases the risk. If they're spayed before their first heat cycle, the risk of mammary gland tumors is almost zero. Even spay after one heat cycle, which is, at least in my practice, the more current recommendation for other health benefits, such as orthopedic issues, that increases the risk to 7%, which is still quite low, but it definitely increases after more than that one heat cycle up to 1 in 4. So this is just a little diagram of the different mammary chains in the dog. Diagnosis of these guys, you can aspirate them. It can be fairly difficult to determine whether the mammary cells you're seeing are cancerous versus benign. So biopsy is the definitive diagnosis. Staging, these particular tumors tend to be more likely to spread to the lungs. So we generally, any dog that has a mammary tumor will generally take thoracic x-rays prior to doing surgery, because if you already see spread to the lungs, removing the tumor is not really going to do too much as far as prognosis goes. So for treatment, surgical excision is the gold standard, and then submitting for histopathology. There are a couple of different types of mammary tumors. I just kind of grouped them together. Fibroadenomas are benign. Mixed mammary tumors can be benign or malignant. Then adenocarcinoma is malignant, and inflammatory carcinoma is probably the worst of all of them. It's definitely malignant and it's pretty aggressive. Chemotherapy, radiation, and anti-estrogen therapy can be used for incompletely excised tumors. Prognosis for these guys, kind of as I was talking about before, fibroadenomas are benign and have a great prognosis with surgical removal. Mixed mammary tumors can kind of go either way. And unfortunately, as with the mast cell tumors, a lot of mammary tumors are mixed tumors. So it really depends on what the pathologist sees under the microscope, and they'll give you a pretty good idea on the histopathology report. The adenocarcinomas are malignant, and also prognosis depends on multiple factors that are read by the pathologist. Inflammatory carcinoma is the most aggressive, spreads pretty early, and is very difficult to treat, but it actually in dogs accounts for less than 5% of mammary tumors. It's not super common, but when it is, it's not good. Larger tumors have a worse prognosis, as does evidence of spread to the lymphatic system. And a lot of times when you're removing the mammary tumor, you'll get part of those lymphatics, so the pathologist will look at both the tumor and the lymph system to determine whether there's already been spread. Deeper tumors are worse prognosis, as are ulcerated tumors. But kind of in general, to summarize, approximately 50% of malignant mammary tumors will have already spread by the time of surgery. But the other 50% are usually confined to just what you see, and surgery can be curative. So, not as bad as some of the other cancers. And this is my Groa Doberman. She dug up my flowers and planted herself there instead.
With those, what's usually, do you just like find a lump or something?
Yes, typically a lot of times if people, the dog's laying over and people are scratching their bellies and they feel something, or during a physical exam, I usually palpate the mammary chain and we'll find something in there. So.
And then obviously there's a lot of pros to fixing them early.
Yes.
But I've heard as well, our dog had epilepsy,
Mm-hmm.
and I've heard that if you fix them too early, sometimes that causes epilepsy.
There are, before, I'd say probably maybe 10 years ago or so, the thought was everything should be spayed before the first heat cycle, everything should be spayed and neutered by 6 months. Mm-hmm. That has evolved quite a bit. The benefits can be epilepsy, orthopedics. A lot of times if we allow their growth plates to develop a little bit more and such, it'll decrease their risk for ACL tears, especially in the large and giant breed dogs. So you kind of have to balance whether, because 7% risk after the first heat cycle is still very low. So we are recommending, at least my practice, and there's a lot of different thoughts on it, spaying after the first heat cycle, which generally in most dogs ends up being around 8 to 10 months.
And a lot of shelters and rescues will not let you.
Yes, and I understand the reasoning behind that too, because their goal is reducing overpopulation, and they don't want to let rescues out of the shelter or out of their rescue group without having them spayed and neutered, because you're putting a lot of responsibility on the pet owner to make sure it happens. So we have dealt with some rescue groups that if we wrote a letter stating that we recommended a later spay or neuter, they will accept that, is kind of how we've gotten around that. And there's nothing to say that early spay and neuter in the majority of dogs that are not large or giant breeds is a bad thing. So.
Do you know the chances of the increase of epilepsy coming up when spaying early?
I haven't heard a lot about that one. I'd have to look into it, but sure. Yeah.
Male dogs, and what do you recommend? Because like females, you said after the first heat cycle.
Male dogs, we're kind of going with the same age as the females, so generally 8 to 10 months. And some of the giant breeds, my practice tends to see a lot of giant breeds. We see a lot of Danes, Mastiffs, Greater Swiss Mountain Dogs. We're waiting even over a year. So, all right, we're going to move on to kitties. So we're going to actually talk about mast cell tumors in cats, because there's quite a bit of difference between dogs and cats with mast cell tumors. We're also going to discuss vaccine-associated fibrosarcomas and osteosarcoma in cats. So feline cutaneous mast cell tumors, or mast cell tumors that are in the skin of cats, are more likely to be benign than in dogs. Cats, however, tend to have the visceral form of the disease, or the internal organ form of the disease, more commonly than dogs do, and it is usually malignant. Cats with mast cell tumors, usually over 4, but the more common age is between 9 to 11 years, so definitely an older kitty disease. The skin masses can look very similar to that of dogs. The visceral form of the disease usually affects either the spleen or the intestines or both, and the cat typically presents with gastrointestinal signs, so vomiting, diarrhea, not wanting to eat. Diagnosis of mast cell tumors in cats is very similar to dogs as well. A fine needle aspirate of a skin mass would confirm the presence of mast cells. Histopathology is required for grading system and classification of cutaneous mast cell tumors. It is a little bit different in cats than it is in dogs. They're separated into two different categories, mastocytic and atypical. Mastocytic itself is separated into also two categories. Well differentiated, basically meaning they're more distinct, have more distinct borders, and they tend to have a more benign behavior. Pleomorphic means they're a little more widespread, don't really have distinct borders, and those tend to be more malignant and carry a poorer prognosis. Atypical mast cell tumors, more common in young kitties, and especially for some reason Siamese tend to be predisposed to these. These may spontaneously regress or spontaneously go away on their own without surgery. And because of that, there are thoughts out there that it may be more a reactive process, a reaction to some sort of stimulation, as opposed to a true cancer. Visceral mast cell tumors don't have a grading system, but they're usually pretty bad, unfortunately. So this is just a diagram more of mast cell tumors, or mast cells, these little guys here with the little purple granules. Treatment in kitties, surgical removal, again, is the treatment of choice, especially for cutaneous mast cells. Removal of the cutaneous mass is less likely to be curative in the dog as in the cat. They are more likely to redevelop a mass at the site or potentially one somewhere else, but they tend to have a more benign behavior. Splenectomy, or removal of the spleen, is indicated in splenic mast cell tumors. Intestinal mast cell tumors, if there is truly a distinct mass in the intestines versus it being spread throughout the intestines, you can remove that. But typically, unfortunately, it's already spread, especially to other organs. Chemotherapy is not utilized in the cat nearly as much as in the dog. There's not a lot of research behind it, and most people don't do it. Same kind of thing with radiation therapy. And the tyrosine kinase inhibitors, in this particular instance, Kinovet, are not used as frequently either. Mast cell tumors are not super well understood in the cat, as are a lot of things in the cat. We call them little aliens because they tend to behave in a lot of ways very differently than dogs. All right, on to vaccine-associated fibrosarcomas in cats. These usually present as a solitary firm mass. Usually there is some adherence to the underlying tissue, so you can't really move them around, and usually at the site a vaccine was given. It's usually the killed vaccines, which the more common ones that we use in kitties are rabies vaccines and the feline leukemia vaccines that are involved in this particular syndrome. They tend to be more aggressive than just a regular fibrosarcoma that's not associated with the vaccine. They can actually be associated with an injection of any sort, but more commonly with the vaccines. Incidence is very low. Studies have reported anywhere between 1 in 1,000 and 1 in 10,000 vaccines given, which I know is kind of broad range, but still pretty low. The adjuvant that's in the vaccine, or is a substance that keeps the virus in the area of vaccination for a couple weeks so the immune response can take place slowly, is thought to cause a low-grade inflammatory reaction that leads to precancerous changes in the cells. It can take as short as 2 months and as long as 10 years for these to develop, but usually it's within 4 years of the vaccine. And the question that is usually associated with these is, should I still vaccinate my cat? And the answer to that for me, for sure, is yes. The incidence of vaccine-associated tumors is very low compared to the incidence of the actual diseases that we're vaccinating for. So, and they're pretty devastating diseases, especially rabies, which is pretty much 99% of the time fatal. And we recommend talking to your veterinarian about what vaccines are appropriate for your cat, as opposed to just vaccinating them for everything. Personally, my opinion is cats that are not outside and are not having contact with other cats do not need to be vaccinated for feline leukemia. Rabies, unfortunately, is a legal issue. Everything has to be vaccinated for it. But I am pretty choosy in what cats I vaccinate for leukemia. Diagnosis in this case is a little bit different. You actually want to biopsy a small piece first to determine if it's a vaccine-associated fibrosarcoma, as opposed to just taking off the whole mass. Because if it is, and that little biopsy piece comes back as a vaccine-associated fibrosarcoma, it's going to be a pretty major surgery. You actually want to get about 5 centimeter margins around the mass, because that's going to give you your best chance for a cure. Staging involves looking at the regional lymph nodes, so again, the lymph nodes that are associated with that particular site on the body, and taking chest x-rays. For incompletely excised vaccine-associated fibrosarcomas, radiation therapy can be used. The method of vaccination in cats has changed a little bit over the years. I'm a little more specific in cats as opposed to dogs where I'm giving the vaccines. So typically rabies is given in the right rear leg, leukemia in the left rear, and the FVRCP or the upper respiratory vaccine given in the right shoulder. And you want to actually try to vaccinate as low as you possibly can on the legs. And unfortunately, the reasoning behind that is if there were to be a fibrosarcoma associated with it, you can amputate the leg. And that's going to give you a pretty good chance for a cure. So there are, and I forget if I talk about this later, there is a newer non-killed or live rabies vaccine in cats. The debate on this one is, with killed vaccines in cats, you can vaccinate every 3 years. The live vaccine does have to be given yearly. So the question is, are you better off vaccinating yearly with a non-adjuvanted vaccine, or knowing that even an injection of any kind can potentially set this off? Or are you better off using an adjuvanted vaccine every 3 years? So in my particular practice, we still use the killed vaccine every 3 years. But it just kind of varies depending on how people feel about it. So prognosis for these guys, with pretty radical surgery and radiation therapy, their median survival time is about 32 months. It is possible just to remove them and not do radiation therapy, probably not as long as a median survival time. Any questions on those? Sure.
What is the survival time if you amputate a leg that it was in?
Amputation, I think, gives you a much better chance for a cure because you are getting really good margins and taking it off of there, but you would still want to do staging to make sure it hasn't spread somewhere else. So.
Have you ever had to amputate with that?
Honestly, I have never seen one of these in the almost 10 years I've been practicing. So.
Do dogs ever get that?
Dogs are far, far, far less likely. It does happen, but it's more of a cat thing. They are little aliens. That's pretty much the conclusion I've come to. They are. They're great, but there's many, many things you would think that they would behave similarly to dogs, and they are complete opposites.
And that doesn't matter age or breed or anything?
Nope, can occur in any of them. So. All right, our last one is osteosarcoma or bone cancer in cats. This is pretty, in this regard, is actually they behave fairly similarly to dogs. It presents as a lameness or a painful swelling around a bone. This is usually an older kitty disease, 8.5 to 10.7 years. It's less common in the cat, but does still occur. More prevalent sites, kind of similar to dogs, are the distal femur, so the very end of the big bone here by the knee, the proximal tibia right up here, the humerus, or in the shoulder, and the digits or the toes. Diagnosis involves radiographs. You can try to fine needle aspirate these guys. It's very hard to aspirate bone. Biopsying, again, very similar to, at least in my opinion, unless you're planning on amputating, I would not biopsy this because you're going to weaken that bone and they can already be predisposed to pathologic fractures, and I feel like taking another piece of that bone out is just going to perpetuate that. Can be difficult to distinguish from fungal disease, so you can do fungal titers and other things to kind of determine that, especially if it's a younger cat that has a travel history. We don't tend to have a lot of fungal disease in Colorado, but places like Arizona and basically the rest of the US have quite a few fungal diseases. So. Treatment, gold standard is amputation, unfortunately. Cats are not commonly given chemotherapy after amputation as dogs because their survival time with surgery alone is actually pretty good. Radiation therapy can be used if the tumor is on a flat bone, which can be like tumors of the jaw, tumors of the spine. You can do radiation there because you can't really get good margins on those areas. And then palliative care, like dogs, involves anti-inflammatories and analgesics or pain medications. Prognosis, that does have a lower metastatic rate than dogs, actually about 5 to 10%, and median survival time with amputation alone is 24 to 44 months. So not nearly as devastating in cats as in dogs. So that is all I have for you guys today. Does anybody have any questions?
My cat's going on 6 years survival osteosarcoma.
Yeah, they tend to do a lot better.
Luckily, and they got good margins. It was on his dewar.
Yep. The other kind of just random trivia fact that I like to throw out there, if you're doing an exam, doing x-rays for a lameness, and you see a lytic digit on one of the toes, it can be a metastatic lesion from a primary lung tumor. So anytime you see any sort of lysis or any sort of anything affecting the toes, you always take chest x-rays. For some reason, it's a cat thing. Dogs don't tend to do that, but.
Just
All right, well, thank you guys for coming.
thank you.
Appreciate it.